Our program was held in Chinatown, which is easy access to the participant and which is very familiar location to them as well, as they are Chinese. And also in designing our program, there was a combination of Chinese medicines and Western health promotion strategies. So what do we mean by that is, given the fact that your food remedy is very important in our Chinese culture, so in parallel to have the food nutrition information, so we have the food remedies for managing the side effects of cancer treatment. For example, quite often that when the way we manage the vomiting or nausea, okay, in our Chinese health promotion or Chinese health strategy is, we eat some ginger or having some herbal medicine to manage it. So in order to have that as a culturally sensitive, we incorporate all these food remedies for managing the side effects of the cancer treatment. So in one of the sections, we have discussed the role of traditional Tai Chi in promoting physical fitness and stress management. So in terms of linguistically appropriate, we conduct the program in Cantonese, and all the written materials are also in Cantonese, in Chinese. Okay. So in the evaluation phase, we use a combination of quantitative and qualitative approaches, and we got 29 women enrolled in the program. At the final stage, we got 24 participants complete the evaluation form and participate in the semi-structured evaluation discussions. And here gives you some demographic background of these 24 Chinese women. So the majority, they are in the age group of 40 to 59. And most of them, they come from China and Hong Kong. And from this information, you can see, even though they have been in Australia more than 20 years, so nearly half of them, they have been in Australia for more than 20 years, but they still doesn't have very good English proficiency. As you can see, more than half of the participants, they only speak little or not at all with their English proficiency level. So the feedback towards the program, so the majority of the participants either strongly agree or agree that the program improved my understanding in managing my condition. So we got 100% positive feedback on the program in improving their understanding in managing the conditions. And the program increased my confidence in my ability to cope with breast cancer. Again, we got 100%. And the program provides opportunity for me to share my concerns and anxieties. The information provided by the program suits my needs. Or the last one, if the program is rerun in future, I will recommend others to join. So we found the program we found the result is really promising. Okay, so according to the qualitative finding, so that is one of the examples of the participant her feedback on the program. I found this program is fantastic because it is designed for our Chinese people and conducted in our language. I know there are many cancer support groups and information groups out there, but they are designed for the local people, and I don't find them relevant to my needs. So in this feedback, we can see how they really appreciate the program that's provided in the Chinese relevant to the Chinese culture and in their language. In terms of the informational impacts of the program, I like the way that the information provided in this program is relevant to us Chinese people. So for example, I really appreciate that the information in the nutrition section included Chinese food remedies. Among the Chinese, food is very important in promoting health and relieving symptoms. That is referring to what we found the program was designed as culturally sensitive because it's relevant to Chinese culture. And in terms of the psychosocial impact of the program, so we Chinese are not used to sharing our feelings, but in here, I feel free to share my concerns and struggles. Since the group members all have the same disease, so they understand me. So I guess that is quite common in all cancer support group. Yeah. But in this, we can see how that Chinese cancer support group relevant to them. I did go to the local cancer support group once, but not again. So I found that having members with the same culture and language makes it easier to share experience, probably because we understand each other more. The support I experienced here was something I never find in a local group. I think that is echo to the literature why that the people from minority culture, they are underrepresented in the local cancer support group. So in conclusion, is cancer support group needs to be designed to be concurrent with the cultural references of the group's member. By providing cancer information and psychosocial support relevant to Chinese culture, support group can effectively address the need of Chinese Australian women with breast cancer. And if you want, you have the details of the program, and that is the publication we did from this project. Thank you.
Thank you so much. I think that's probably the first session I've ever had to chair where someone was early. I didn't know quite what to do. There should be other kind of streamers going off. Thank you. Our next presentation is from my dear colleague, Mayanne LaFontaine, who is the Program Manager of Tobacco Control in the Cancer Prevention Unit at the Cancer Institute, and she'll be talking about awareness about signs and symptoms of lung cancer in at-risk populations in New South Wales.
So today I'll be focusing on the awareness of the signs and symptoms of lung cancer, particularly in culturally and linguistically diverse communities. So just by way of background, lung cancer in New South Wales is the leading cause of cancer deaths. In New South Wales, it has a relatively low 5-year relative survival rate, sitting at 16%. And we know that in most cases, diagnosis occurs late, so that's particularly in stages 3 and 4. And that if we can diagnose lung cancer early, it can lead to improved outcomes. So here we are sitting at 16%. We know that countries such as Canada have a relative survival rate of 20%, so we can achieve better outcomes. The Cancer Institute New South Wales has developed a lung cancer program, and the aim for this is to increase the early detection of lung cancer and contribute to better cancer outcomes. It also is to increase the 5-year survival rate of patients with lung cancer through early diagnosis. So the Institute has developed multiple projects that span the lung cancer journey. And today I'm really going to focus on one that is aimed at developing a community awareness campaign. So we know that mass media campaigns directly or indirectly influence positive behaviour change or positive behaviours or reduce negative behaviours across large populations. And part of the process of campaign development is conducting research. And that's really looking at trying to understand the issue and the situation, and particularly from the perspective of our target audience. So for this project, we've defined the target audience as smokers and former smokers over 50 years, given smokers and former smokers are at higher risk, and also because lung cancer usually presents over 65 years. We've also identified Aboriginal peoples over 40 years, given their high smoking rates, earlier uptake of smoking and earlier presentation of the disease, as well as those from culturally and linguistically diverse communities, again over 40, and prioritising those from the Arabic, Chinese and Vietnamese communities. And this again is because of the high smoking rates within those communities. So what did we need to know? Our research was really designed around 3 core questions. They were, what do at-risk populations understand about lung cancer? So what it is, who gets it, how it's diagnosed and treated, perceived risk and prognosis. What is the patient journey for lung cancer? And this was from a patient and practitioner perspective. What are the barriers to earlier diagnosis of lung cancer that need to be addressed? And again, from a patient and practitioner perspective. So we conducted a mixed methods approach to our work, and this consisted of conducting focus groups with mainstream smokers, ex-smokers and never smokers, focus groups amongst our core communities, consultation groups with Aboriginal communities, interviews with GPs and interviews with lung cancer patients, as well as a quantitative component where we conducted a population survey which was based on the UK Cancer Awareness Measurement Tool. And this will be used as our pre and post campaign evaluation. So today I'll be focusing on the focus groups we conducted amongst our core communities. In total, we conducted 7 groups, 2 with Arabic, 1 with Mandarin, 2 with Cantonese groups, and 2 with Vietnamese groups. So what I'll be doing is going through the results from our research, but using behaviour change theoretical constructs to lead the discussion. So perceived susceptibility. There were differences between the perceived susceptibility amongst never smokers who perceived their risk to be low, as opposed to ex-smokers who perceived their risk to be the same as never smokers, but smokers who perceived that their risk was higher, but that it could be offset by otherwise healthy lifestyles. What we did find was there was a view that everyone was at risk due to environmental factors, but you needed an accumulation of those factors. So it wasn't just smoking or passive smoking, but other factors such as air pollution, agricultural food production, and an unhealthy lifestyle. Arabic smokers also thought that thinking about lung cancer increased your risk. And interestingly, the concept of body immunity came up, and this was particularly amongst the Arabic smokers and the Cantonese smokers and non-smokers who believed that you could build immunity and that would protect them against lung cancer. And this was seen to be from the nicotine and chemicals found in cigarettes. Perceived severity. Lung cancer was definitely seen as a serious illness and in most cases terminal. There was some awareness that survival depended on how early the cancer was detected. Amongst the Asian groups, there was the feeling that prognosis depended on the patient's attitude and good mental health. So there was this strong belief that positive attitude and good mental health could even cure cancer. In terms of the knowledge of symptoms, there was general awareness of the symptom of coughing up blood and weight loss as a symptom of lung cancer. But with other symptoms such as, a persistent cough, wheezing, repeated pneumonia, there was uncertainty about these. There was a general agreement that lung cancer would manifest differently in different people. Besides the Mandarin smokers, all said that chest pain, pain in the abdomen, fatigue were not symptoms. But overall, the list of symptoms were concerning. However, most participants didn't immediately associate them with lung cancer. In terms of knowledge of treatment, there was a generally low level of knowledge of treatment, except with the Mandarin groups who seemed to have the highest knowledge. Arabic-speaking smokers had the lowest and hadn't heard of any treatment being successful. Treatment was seen as something to provide a small extension to life, but it could not combat the cancer, and ultimately it would just reduce in quality of life. Alternative therapies were also mentioned, and this was particularly so amongst the Asian groups who combined traditional Chinese medicine with Western medicine. The perceived benefits. There was a really high trust and belief in GPs, and this was especially so with the Asian groups who would be really compliant with the advice and direction given by their GP. We also explored how people thought their GP would respond with a direct request for a chest x-ray, and most felt that their doctors would respond positively to this request. The Arabic groups, however, were less positive about this. There was also this fear of specialists, and this was seen as because the idea of going to the specialist meant that they had something really serious. However, the Arabic non-smokers saw this as a reflection of their GP not being able to diagnose it themselves. The Arabic groups were also concerned about the time wasted when conducting tests with GPs, being referred to a specialist, waiting times for appointments and things like that. The perceived barriers. There was an assumption that if they experienced some of the symptoms, they would not immediately associate with lung cancer, so that it could be something else. And this was especially so amongst non-smokers, So while coughing up blood was something that they would immediately see their GP about, other symptoms such as fatigue, a cough that changes, and pain in the abdomen would not be something that they would seek immediate attention for. Some discussed that they would really wait 1 to 2 months before doing something about it. For some groups, they would generally talk to their families and friends about these symptoms before contemplating and seeing a GP. And amongst the Cantonese groups, there was a preference for Chinese medicine, which could lead to a delay in seeing their GP. In terms of self-efficacy, there was a low confidence in symptoms recognition, and this is reflected by the low awareness of the symptoms themselves. There was hesitation to discuss symptoms with GPs, and this was particularly so amongst the smokers. There was mixed reaction to the idea of asking one's doctor to be tested for lung cancer when early symptoms were noticed, and ultimately variances in confidence to request an X-ray from their GP. So in conclusion, all groups wanted more information about the signs and symptoms of lung cancer. I'll go through now some of the key variances between the cultural groups. With the Arabic people, they were generally more pessimistic in their outlook, so obviously linked to them not hearing of any successful treatments in other people. There was that real denial about the risk associated with smoking, the stigma regarding cancer, so that fear of thinking about cancer, and not being as receptive to visiting their GP. The Chinese people would use alternative therapies first instead of seeing their GP, leading to late presentation. However, once they did visit their GP, they were generally very compliant with the advice and direction given. The Vietnamese people also had a high trust with their GP and mentioned that they would act on concern regarding symptoms, but again, this would be linked to recognising the symptoms in the first place. So with regards to our next steps, we feel that we do need a phased approach to communicate to our communication to really tackle the obstacles such as the risk factors and the fatalistic attitudes towards cancer in general. So we really need to address that fear and perception that lung cancer is a death sentence. After that, we can then communicate the lung cancer signs and symptoms, increase awareness of treatment and potential survival, particularly if it is detected early, and increase the urgency to act when symptoms consistent with lung cancer occur. What was important from the lung cancer patient's perspective is really providing that element of hope in our communication, that if treated early, there are improved outcomes. Thank you.
Thanks, Marianne. The next presentation is the first of the grants that have been provided by the Cancer Institute, and the title of the presentation is A Community Partnership Program for Promoting Cancer Awareness and Screening Practices Among Chinese and African Australians. Dr. Canis Kwok is also one of the lead researchers on this project. However, it's being presented today by your lady Organ Siji, who is the Deputy Director, Learning and Teaching Curriculum, School of Nursing and Midwifery, University of Western Sydney. Thank you.
Thank you very much, everyone, for coming to this session. As it's been introduced, this is the project itself is at the initial stage of the presentation, and it's a community partnership program that is aimed at promoting cancer awareness and screening among the Chinese and Africans in Australia. The main focus of my presentation is to really, dwell mainly on the methodology that we plan to use for this particular project. And I'll quickly say that we aim at developing and implementing a tailor-made, culturally sensitive and linguistically appropriate cancer awareness program for addressing misconceptions and myths around cancer and promoting cancer screening among these cult communities. A little bit of background shows us from the literature that talking about cancer is a taboo topic among these two communities. And like I've heard from the two presenters, talking about cancer is like, receiving a death sentence. And most of the time, women, considering the socioeconomic status they hold, gender issues, they usually, hold back in accessing the services that are available. So this particular project comes up handy in terms of increasing the women from these communities in accessing and using the screening services. The project is in 3 phases. And the first part of the first phase will take us to a kind of a cancer awareness educational sessions and media presentation. During that session, what we plan to invite cancer survivors and those that have experienced screening to come and talk about their experiences of the services that they have received, and not only that, the experiences with screening. That particular approach is considered to be relevant and appropriate for the two CALD communities because they rely a lot on storytelling and the experiences of others. Most of the time you hear them if somebody is telling them about a particular issue at any time, you tend to hear them, have you experienced it before? What was it like for you? Can you tell me about something about it? Most of the time they might not really want to take the bold step to access the services, but when they hear somebody's experience about dealing with the services and what it has meant for them, and perhaps even seeing individuals that have passed through the experience, talking to them about being survivors, we consider that as something that can encourage screening participation among the community. During that particular session, we also aim at, commencing the, giving out written materials, educational product and, pamphlets to the participants that will be there. And from the first session, we also plan to commence the second phase there by asking participants during the first session who will like to take up screening services. Or some of them might have used might have been screened before. We anticipate that quite a number of them might have not even been screened before. So during this session, we intend to organize group screening session whereby as many people that nominate, even to take up screening, will be referred for services. And we also intend to liaise with breast screening services to come around and screen them. For example, among the Africans, we are organizing to link up with the Women's Health Center to do the screening, and with the Chinese population, there is arrangement with the Chinese GP to organize that for them. And still looking at the community partnership, the issue of community engagement is very important, and sustainability is something that is of focus to us. And in addressing that, we are planning to have community health assistants who will be trained, and they will be the one that will serve as advocates and carry the message on, even within the community. And to that extent, we believe that the message will be carried on even after the program or even after the project. The message will be carried on within the community. So what we are doing at this particular stage is that we've already got ethics approval for the project, and we are liaising with the community. Canas already have some groups that she works with, and I have strong link also with the African community. So in that way, we are sensitizing the community about the project, about the program, about the educational session, and there is a lot of positive feedback so far. And we actually hope to be able to present, more progress by the time we have subsequent conference that may be organized. But so far, we are really excited about it, and it's been an exciting journey. Other things that I would like to mention in terms of it being a tailor-made, culturally sensitive strategy is that we are also thinking of engaging the local newspapers, radios, and community channels as well, so that because those serve as avenues that many Africans and Chinese use for first-hand information, and they'll be presented in the languages that they are familiar with. And those are avenues that have not really been used or that have not been tapped into in previous initiative. So we think those two communities are going to benefit from these avenues of passing the message across. One thing we also know is that most of the time, even places of worship, like such as the churches or even the mosques, to a great extent have been underused. So we are thinking of even using those avenues as well in accessing the participants. The Africans, most of them are very religious, and even Chinese, so we intend to even organizing that breast screen and their vans go to some of the churches. I have 2 or 3 churches in mind that are already willing to actually open their doors in making the women available even to access the screening services. So this way, we are intending to having a long-term engagement with the communities, continuing liaising with the community health advocates, and hopefully we will have opportunity of evaluating the program at the end of the project. Thank you very much.
Thank you very much. The second presentation of our Cancer Institute grants is by Dr. Astrid Perry, who's the Manager of Multicultural Health Service at South Eastern Sydney Local Health District. And the topic of that presentation is Silence and Suffering, Using Applied Theatre to Promote Prevention Measures and Reduce Stigma Related to Cancer. Thank you.
Thank you. It's a great pleasure to be here today and talk to you around a project that's a little bit different in health promotion in that it is theatre-based. It's modelled on a project that we've already had, which was also a theatre-based stigma project in mental health called Fear and Shame. I did bring a little bit of a clip of the footage if we have time. We've evaluated that previous project extensively with 275 bilingual interviews, or interviews in the Macedonian language, really, finding that it facilitated the community in talking around stigma and mental health issues and seeking health services earlier and actually being able to talk with their family and community members around mental health. So we thought we'll replicate the same kind of methodology in this project around cancer because, as you heard already, stigma is an issue for CULT communities. So I'm going backwards, sorry. Here we go. So in this project, we address stigma, myths and misconceptions associated with cancer. And those the stigma itself, we've heard a couple of things, prevent help-seeking behaviour, but it also has kind of far-reaching implications for some community in that I've never thought of it myself, but marriage prospects, for example, can be an issue for the next generation. So there are real fears around who is going to find out in the community that your family has cancer. And some of those things really come from the kind of information session that we do where people walk away with snippets of information that then doesn't quite fit the context. So inheritance is not an issue with all cancers, for example, but maybe in some there is a stream of inheritance. That's a possibility. But in a community then it has a life of its own. So one of the things that we also want is looking at key messages. And I think as practitioners together, we need to think about what the key messages are and be consistent about them. Because they can, in a community where they speak all the other language and there's nobody else hearing what is being talked about, that can lead to a lot of misconceptions. So we want to promote access to cancer prevention, screening and treatment services, and that's from the community perspective, because a lot of people actually don't go because they don't want to know, because if you know, you've got to deal with it in some way. But also, in many communities, is also a fatalistic approach in the sense of, well, if it's God's will, then it's God's will, and I deal with it then. So there is sometimes no conception that early screening could make a real difference. There is also, as mentioned before, the death sentence idea, And if people believe they're going to die anyway, then if they have cancer, then it kind of doesn't make much sense to go early because the outcome will be the same. So it's some of those misconceptions we actually have to break down. And so we found theatre is a possible means to do that. So we're planning to do 3 plays for 3 different cultures, so Greek, Macedonian, and Arabic speaking. And they will also all be in English so that we can use it with second generation. So the objectives, 3 short theatrical plays and associated resources. So those resources are to be able to lead discussion with community groups, like some of the groups that others are organising, so that you can use the footage as trigger questions. So the plays will be performed as well as being available in DVD. So we want to engage communities and key stakeholders in the process. So we've already had a workshop with service providers around the key messages. And then we will have workshops with each of the community members to better understand what the issues actually are around the stigma. The rationale for those communities, they experience a high level of stigma. They are not the only ones, but from those ones we certainly do know. They are relevant for our area, so I'm from southeastern Sydney, but they're relevant for the state as well. They experience significant barriers, so we know that there are low screening in, for example, breast screening, pap tests, and so on. There are large communities in New South Wales and our districts, as I just mentioned. They have a significant gap between the community cultural understandings of cancer and the health promotion messages. So there is a disconnect there. And they have a long history of community theatre. So all those groups actually have community theatres in Sydney. And so we're hoping with 2 of them we've been successful. The 3rd one we're still negotiating. But we're very confident that we will be able to manage that. So our project timeline is researching the problem, and that's mainly qualitative around the attitudes. And then, made a little mistake. I left mental health in there. Sorry. Development of the suffering and silence script. So that was that title was workshopped also because there is this silence about not talking about it. So then it's culturally specific, and then the script writing, and then early performances early next year, and then community discussion around the triggers, what are good triggers that come out. So there'll be another set of focus groups that looks at the footage so that we can see where we should structure the trigger questions and so on. And then beyond that, once we have the plays, we'll have the footage, and we will develop an e-learning tool from that, which is outside the project, so that's not the funded part. But we find it a very useful way of getting clinicians to engage through e-learning. So that's then our 2nd or 3rd phase, and the evaluation of the project and a project report will be around the play. That's our project. So we're certainly looking forward to engage both with the communities but also with theatre producers and writers, and come up with some interesting plays. Thank you.
Thank you, Dr. Perry. Perhaps at the end of the workshop we might be able to screen the examples, if that's okay. Our final presentation today is from the Cancer Council of New South Wales, Mamta Powell, the Program Manager there, who's going to be speaking on engaging youth in reducing the burden of liver cancer in culturally and linguistically diverse communities. Thank you.
Good afternoon, everyone. Welcome to the last session of this workshop. I'll try and keep on time. I just thought I'd start with some background information. 46% of primary liver cancers occurred in migrants. Where does this information come from? Cancer Council New South Wales published a very important report on cancer incidence in New South Wales based on 2006 census data, which described the most common type of cancers for the 20 most common cancers reported for the 25 most common places of birth. Of all cancers, liver cancer stood out to be the fastest rising internal cancer, particularly for migrants born in communities, in countries, with a high prevalence of hepatitis B. Worldwide, there are approximately 2 billion people infected by Hep B virus. Chronic hepatitis B is one of the top 10 causes of death worldwide. and up to 1 in 4 people with chronic Hep B will die of liver cancer or liver disease if not appropriately managed or treated. In Australia, there are approximately 200,000 people estimated to be living with chronic Hep B. Over 75% of those are either born from Aboriginal Torres Strait Islander background or people born in countries with intermediate or high prevalence of hepatitis B virus, and mostly acquired it at birth. 8% of people living with chronic Hep B reside in the Southwest Sydney Medicare local area. There's a map there which shows the highest rate of liver cancer in New South Wales. So the problem is that people are unaware that they have chronic Hep B and it's linked to liver cancer. Hence, it's also called the silent killer. There are a lot of existing myths and misconceptions in the community around diagnosis, routes of transmission, and treatment and management. So why youth? Because youth are fun and exciting to work with. They're energetic and have a lot of ideas. Also, youth are an important part of Australian society and make up to 20% of Australia's population. In April 2012, Cancer Council participated in Bring It On Youth Festival, which was held at Fairfield LGA. We had an awareness stand and an expo where we raised awareness of chronic Hep B and its link to liver cancer, and conducted a survey which had some very interesting results. As you can see on this picture here, 82% correctly identified where their liver was in their body, which was quite surprising. The other results also found that 67% correctly stated chronic hepatitis B to be the most common cause of liver cancer, and 88% correctly answered that a blood test was the only way to find out if you had hepatitis B. And surprisingly, 76% knew that there was a vaccine available. So based on this, what did we do next? We developed some key partnerships and collaborated with the council and the Fairfield Migrant Resource Centre, which is the part of Cabramatta Youth Team, the Cabramatta Community Centre, and the high school. We also conducted a youth consultation in August 2012 with youth from different coal backgrounds. And the results so far have been fantastic. They have a lot of great ideas, and they have ideas in terms of how to take the message home and inform mum and dad at home about the risk about chronic hepatitis B and liver cancer. And there's lots more coming. Watch this space. Thank you.
Thank you very much. Another rare example where it went faster than I anticipated. So we're actually a little bit ahead of time. If I can invite all our speakers to just join the panel over here. Now is the opportunity for anyone with questions or comments to think about what they might be. We do have some members of the Cancer Institute here with microphones, and we can... Oh, Patricia here and Kendall at the back. And because I'm the first one with a microphone, I figured it was okay if I asked the first question, in the absence of other people getting around with them. So I'm particularly interested in probably a member of the panel, all of them answering this question if that was possible. Given the many years of experience you've all had in developing and implementing programs in CALD communities of the innovative nature that you've done to date, I'm particularly keen to know what you think the key enablers are for those programs to work. What makes them successful? I'm going to pick any end to start. Astrid, what do you think?
Well, I guess it's kind of clear from all those examples that an ethnic-specific approach probably will get most engagement. And what will be important is actually, get the leadership involved. For those who the GP is an important link, that's great if we can involve them, but for others sometimes it's other community leaders that have a say or are well respected in the community that can make a real difference.
Great.
Quite similar to Astrid, it's really understanding that there are variances within communities. I guess for us, one of our key learnings is that there is no one message fits all, and understanding how you can really influence those barriers to seeking help or treatment. With some other projects, it's also really understanding about the key influences. So similar to what Astrid said, key influences within the community.
So to me, in my last 10 years in working these cancer promotion and prevention programs in Chinese community, I really realized having the community organization involvement is the key point to reach the community. Yeah, and so to me, it's the networking with the organization. I mean, ethic organizations.
From my own experience, similar to what others have said, the key enabler is to include the community right from the beginning of the project, rather than bringing them in somewhere along the line. Let them feel involved. Let them feel have a sense of belonging. And from my experience, going through the ethnic leaders, church leaders, for a number of them, religious leaders, they are key important because community leaders, they tend to, trust them. They tend to listen to them and perhaps even embrace what the religious leaders say. So that's from my own experience.
Yeah, I guess I'm the last one here, but I suppose I agree with all of them. And also it's important to recognize that what involve the community but also understand the community needs is what I think is really important to understand. And yeah, basically involving the community right from the start.
I certainly welcome questions from the floor. If I can ask you just to identify where you're from and your name, and also to where you'd like your question directed, please.
Hi, I'm Shahani. I work with the cervical screening program. I had a question for Dr. Kwok. I'm sorry. I wanted to know, your program seemed really interesting and obviously had fantastic uptake amongst your participants. What were the barriers and facilitators to your recruitment? Because there were only, I think there were only 29, is that right, that you were able to recruit?
No, actually we don't have the problem with the recruitment. We don't have enough resources to cater all the participants. Yeah, so actually because I think that is the first culturally sensitive and linguistically appropriate cancer support group for Chinese women with breast cancer, and as we identify in the formative phase, they find really lack of resources that they need. So because of the limited resources, we can't cater all of the participants. So at the end, we have to screen all those Chinese women with breast cancer. They speak Cantonese. So actually, we have more than 50 women want to enroll, but they speak Mandarin. But the problem with the Chinese community is the two common spoken language, which is Mandarin and Cantonese. So we don't have the problem to find the bilingual health professionals who speak English and Cantonese, but we don't have any resources or health professionals who speak Mandarin and English. So that is the problem. That is the problem we are facing in this kind of research, because as you know, the population of the Chinese who are from mainland China is increasing. Yeah, but the problem is we don't have that health professional that can look after this group of women or cancer survivors. Yeah.
And just one more question, quickly. Were you able to see whether there was any linkage to the outcomes, like in a sense, did they go more often to see their doctors, or go more frequently for their visits and things after participating in the program?
We don't know if they will go to see a doctor more after the program. Yeah, but what we really found is the program has given them some encouragement and some hope. That is some resources in here that should support them. I can put it that way. Yeah. Yeah.
Thank you.
Thank you.
Questions?
I'm Melanie Crane from the Cancer Institute. I've got a question, another question for Dr. Kwok. Just in regards to your program, that the use of the nutrition and the Tai Chi in the program, would it have been effective, do you think, without that element, just the print material, all the material just in language? Do you think, how much do you think, that added to your program, having that element of the complementary medicine?
Sorry, do you mind to repeat your questions?
I'm interested from the point of working with Mayan on the lung cancer element, and just, one of the things that came out there as well was the importance of complementary medicine to the Chinese groups. So I'm interested in how much that would impact the complementary medicine in your program, like if you didn't include that side of things.
So I think the first point is we incorporate that Tai Chi or food remedies is not to treat the disease, is to help them in parallel to the biomedical therapies to manage their side effects. It's not that we incorporate that alternative therapy to treat the disease. It's the management of the treatment and after work. Does it make sense?
It does. Yeah. Okay. Thanks.
Yeah, we incorporate that idea is mainly for their health promotion. It's for their journey after the cancer treatment.
Yeah. I guess, Dr. Kwok, the other thing that you mentioned was the need to make sure you understood where those people are coming from in their terms of their community, and given that is so important to them, to not include it in part of that intervention probably would have downplayed or made it potentially not as successful, because that's where they're coming from their community, aren't they?
Yes, that's correct. Yeah.
Great.
Yeah.
Thank you.
So I'm Heather Shepherd from Family Planning New South Wales. I apologise if I get your name wrong, but Dr. Gunsiji, I'm not quite something like that.
Yeah, you got it right. Thank you.
I'm just curious. I wondered whether in your programme, obviously representing Family Planning New South Wales, we have an interest in cervical screening, and our role is obviously to provide cervical screening. And you were mentioning that you were going to try and do some of your groups and use maybe the breast screen ban and things at the same time. But what we're interested in, I'm wondering whether your programme, what strategies do you think would work in the communities that you're going to work with to encourage them to come to clinics or to go to GP practices for their screening? Because we don't have a mobile screening for cervical screening. And one of the challenges is to try and get people from the communities that you're dealing with to come to go to a GP practice or to Family Planning New South Wales clinics or women's health centres. So I'm wondering whether your programme is going to look into what those things would help in those communities for those people to come to health centres.
Thank you very much. What we are intending to do is to raise what we consider a group of interested women who want to take up screening services. And from the two communities, there is they rely a lot on support from peer support, peer mentoring, sharing of ideas, knowing that they are going for a particular cause together. So even if we are planning that we're going to advance, but even if we do not have, depending on the local district that we're able to get the venue in, we are very, very optimistic that having a group of interested women is like, inviting themselves for baby shower or birthday or something. It's like even passing the message across for them to come as a bunch of group of friends, even for the education session in the first instance. That particular message will be carried on because they will tend to remind themselves. They give themselves phone call at so time we are going for a particular screening, and that is what we are actually aiming at achieving. So even if we want to refer them to a particular, screening services or to a particular healthcare, women's health center, they'll be willing to go as a team or even as a group, because it's my friend is going with me, another friend of my friend, we are all going together there. And it becomes a fun feel, a social thing, and they engage in promote and they will enjoy it. That's what we intend to do.
I think that we need to have some conversations on
it. Yeah. Can I respond? Can I respond to that too? Yeah, thanks. Look, you're quite right with family planning. Unfortunately, we lost a lot of those outlets. So people will not go to the GP, and a lot of the ethnic GPs are male GPs. You'll need to have practice nurses, and it'll need to have a broad concept. We know that in many of the ethnic-specific GPs, surgeries, there are no practice nurses, because they've been there for a long time. And the other thing is, we know that you might get sometimes initial screening with those group concepts, and that's really important flow, with friends and the whole group or whatever. But we know that the next screen does not happen unless the same process happens again. So, yeah.
Can I just respond to that?
Yeah, sure.
Because I know I've been doing some work with the Cancer Institute, so I do know
that's
that
great.
now
Yeah.
on the Find a PAP provider tool, we have now introduced that you can actually list whether a practice nurse is available at that GP practice
That's
to
great.
provide PAP
That's
smears.
wonderful.
So that should be, I'm not quite sure whether it is out and launched that new thing yet, but
Yeah.
that will be something on there now. So it's because
Yeah.
the PAP smear providers are listed by the GPs.
Yeah.
We know that that's an issue, but we have been training many practice nurses over the last few years. We
I
haven't
know,
got so many outlets, but there are many practice nurses out there who can do cervical screening. So if you look at that PAP provider tool, you'll be able to actually see whether there's a practice nurse present at that practice, which would be really helpful, I think, in some of those communities.
And I think Medicare locals provide a new opportunity too to look at some of those things. So,
I also have some additional information for that questions. So as that project, we target Chinese community and African. So for Chinese community, what we plan to do is we have the connection or in collaboration with a group of female GP in Chinatown, Chatswood, Hurstville, and Burwood, and Eastwood. That is the suburb for Chinese people, right? So after the program, they just have a little sticker. Because for some Chinese women, they feel embarrassed to ask for pap smear because they found, I don't have anything wrong, but why? I feel embarrassed to ask for it. So they just have a little sticker to show. So then the GP will have the initiative, okay, so today we're going to have a pap smear. So I think that is important to take the first step. And then after that, they have to follow up. Yeah.
That's a very practical solution. I've got a quick question, if I may. I know that Dr. Perry, in your presentation, you were talking about the fear and stigma that goes around families being associated with cancer. And I guess I'm intrigued about your comments on that, and Dr. Organseji about the need to have family experiences and real stories as being, I guess, case studies or champions in communities. And how do you recruit such champions and case studies and I guess champions within community when in fact it's actually hard for people to put up their hand and actually talk about the fact they've had cancer? So how do you kind of recruit people? Any comments on that?
Yeah. Our focus groups will actually involve community workers that are from those communities because they feel confident enough to talk about it and to get to the bottom of it. In terms of all the different fears. As I said, the one around the marriage prospects, I mean, that came out of a conversation with a community worker. I never thought of it myself. So we're going to have in-depth discussions with those that work in the community all the time, but also work in health or together with health. So they have a kind of an understanding of where we want to get to. And then that gets explored in the real life kind of scenarios, in the plays. So, and the plays will have kind of alternative suggestions. It'll go like, well, if we only went earlier, what, things like that. Yeah.
In terms of our own projects, one major way of recruiting the champions is acting, we see ourselves as having two caps on, insider, outsider. As insider, we are the community ourselves. So it's a matter of networking, engaging with the community. You know those that are living with what. And personally, I have access, from time to time, I get emails from the community, this thing is going on. The same way, they send email to me in telling me that a particular party is coming up, a particular dance is coming up. The same way I will send email out as well. Are you living with this? Are you living with that? And we are doing a particular project, please contact me on so number. And apart from that, by interacting with the community at various levels, you may get somebody who will introduce you to somebody who is having that experience. And because not everybody will be bold enough to come and share the story, but those few ones that are able to share the story, we only need 3 for 3 sessions, and we should be okay.
To start on, we actually have got a successful Arabic-speaking cancer survivor group as well in the St. George area, and they've grown together as a group and have the confidence to talk about it openly. So that's one of our focus groups. Yeah.
So I also promised I would keep to time, and afternoon tea is looming. We probably have time for 1 or 2 more questions if there is a burning at the back of the room.
Brian McCorn, I'm a thoracic surgeon. We know that by the time lung cancer presents with symptoms, it's too late in the overwhelming majority of patients. you review the 4,500 patients I've resected for lung cancer, the best prognostic factor is it was found by chance. So early detection sounds good, but in fact we need to find it before symptoms. So I'd be interested in the plan. I love the presentation about lung cancer, but I'd be interested in this high-risk group now that we have definitive evidence that screening works, something I've always believed and been shouted down by the epidemiologists. We now have the American Lung Program showing a 20% improved survival with CT screening. Why don't we take the big step, instead of getting the report early with their symptoms, of actually in these high-risk groups, which the Chinese and the Arabic are, of engaging with the community, the wonderful talks I've heard from all the presenters today about a screening program for these people.
I'll take that as a comment, but I think you're right. The need to have... Yeah?
No, you're right that there is emerging literature out there regarding screening programs, and particularly what I think you're referring to in terms of the CT scanning. I guess we have reviewed the evidence for that. We've also reviewed the evidence, such as particularly from the UK, where awareness of symptoms has made a difference. But again, like you said, we do understand that a lot of people present at later stage. But again, there still needs to be a lot of work done to raise that awareness of signs and symptoms consistent with lung cancer. So there are a lot of other respiratory symptoms that if we increase awareness of those, certain changes in their cough or persistent cough on exertion, things like that, can help.
I guess it would be a question of policymakers too, wouldn't it? Because we presumably could have screening for anybody 40 plus that's a smoker. Presumably we could.
That's the problem with the previous American Lung Program. It chose too young a target.
Okay.
So you have to choose people over 55. There's a 20% reduction. Let's not lose sight of the information that's come out. For the first time, there is a 20% reduction in lung cancer deaths in the screened population. Get over England. England's so far behind in lung cancer management, it doesn't count. England, you're lucky to get to see a doctor in time to have your lung cancer operation, let alone wait 3 months for a CT scan. So we've got to look at the new data about screening CTs. 20% reduction. First time ever we've seen something show such a significant reduction. I'm all for early diagnosis with symptoms, but the vast majority is still too late. And I'm just encouraging you to take that excellent work the next step onto a screening program at risk groups and involve the community, as I heard said. So in an early involvement, get them to have it. There's no embarrassment like having mammograms or pelvic examinations. They just go in and have a CT scan. Very simple tests. And we should not be sitting back ignoring lung screening program.
Thank you. And look, Innovations Conference is not called that for nothing. So yes, thank you for your comment. Any final comment before I call a close? No. What I'd like you to join me in thanking our presenters. I think if one of the things that they've certainly emphasised